Yes, okay. So we at the Institute for Preventive Health, we are part of the EWUU Alliance. You see the universities here below, the institutes we work with, and of course also external partners, Eindhoven University, Wageningen University, Utrecht University, and the Medical Center in Utrecht. And today we are here because there's been a lot of great research being done at these universities, and we would really like to give a platform to everyone to show their knowledge, to share their knowledge, and also to connect with new partners probably for the future. And therefore we organize these lunch and learn sessions. We also organize conferences and other events for you to meet each other and also find new partners outside academia. So I welcome everyone here today. Here we have the agenda. I'll briefly introduce the EWUU Alliance to you. Then Celia will present, Annemieke will present after, and we have a short Q&A at the end. So please reserve all your questions for the end of the presentation. So here I'll tell you a bit more about the EWUU Alliance. So here you see the institutes again that we work mainly with. We have the Institute for Preventive Health, that's where I'm part of. Together with the Institute for Circular Society, we are the main programs of the EWUU Alliance. Then we work together with 4 working groups: Artificial Intelligence, Living Technologies, CUCO means Center of Unusual Collaborations, and an education team that will always facilitate the different programs for education between the universities so students can attend different courses at those 4 universities. So next, a little bit more about our program. Our goal is to work on Dutch individuals living 5 years longer in good health and decrease the health differences between groups by 30%. We have 4 different themes that we work on: Healthy Start, Preserving Health, which entails adults living in, for example, their neighborhoods and their houses, and we want to have them living longer in good health. Living with Disease is our theme that is mostly focused on cancer, and Health at Home facilitates living healthy in your own environment when you become older. Then we have 3 focus activities. We facilitate research by helping researchers connecting to each other. We help grant writing and proposal developments. And next we have activities for education. We do that together with the education group of EWUU. And as I already told you, we help to build a strong community for more prevention, research, and education. Here we have a QR code, so if you would like to follow us on LinkedIn, that might help you to find more of the activities that we organize, such as the conference that we are now preparing also for November 25th. Yes, I think that's the intro from my side, so I will stop sharing my screen. And then it's up for Celia to start.
Yes, thank you.
The
I
floor
will
is yours.
share my slides. Let's see. Are the slides visible?
Yes.
Yes, perfect. Okay. Well, thank you very much for inviting me to give this presentation. It's so cool to see how much impact and how far this project has reached. So I'm really glad to tell a little bit more about this project. My name is Celia Bannenberg. I am a PhD candidate at Wageningen University. I started my PhD a year ago, but before that I worked on this project for EWUU about diets in Dutch hospitals, and it was part of the working group Circular Society. It was a short project of 1 year, a seed project, and it combined different expertise from Wageningen University, but also from Utrecht University, from the Copernicus Institute for Sustainable Development. We also had people from the Alliantie Voeding in de Zorg, which is a network of healthcare institutions, and we worked with 3 different hospitals. And the ultimate goal of this project is to improve the health and sustainability of food supply systems in hospitals. So it was really great to work with these hospitals and different stakeholders. A little bit of background to understand why this project came to life. Well, hospitals are becoming more healthy and sustainable. They're part of different agreements. There's the Nationaal Preventieakkoord, which aims at reducing overweight, for example. But there's also the Green Deal Duurzame Zorg, where the aim is to, for example, reduce CO2 impact by 55% in 2030. And for this, there are many ways to make it more sustainable, but one is to make our diets more plant-based and to go to a 50-50 ratio of plant-based and animal-based protein in the Netherlands. But why is this so urgent and why is this important? I'll give a little bit of context to that. Well, as you might know, there is climate change. We are currently exceeding the planetary boundaries. We should be operating within this green circle, but there are many different aspects that we are already surpassing, and our food system contributes significantly to that. 25% of the greenhouse gas emissions globally come from the food system, and it also contributes a lot to biodiversity loss and water scarcity. But let's look at the specific impact of foods globally. As you can see here, this is the CO2 emissions per kilograms of food, and the red bars are animal-based products. And as you can see, those have a way higher impact than the plant products. Especially beef on the left side has a very high CO2 emission. But of course, this is per kilogram of food, and it would be interesting to see an example of a dietary pattern, which is why I'm going to show these results from Zaina Vellinga. She looked at the Dutch dietary pattern and its impact on environmental impact. And as you can see on the left, you can see that meat and dairy have a significant contribution to greenhouse gas emissions. This is also the case for other environmental impact indicators such as land use. But for example, when you look at blue water use, it looks a little bit different. So it's always important to take into account these trade-offs, but in general, what we see is that animal-based products have a significant high impact on environmental impact. So let's link this back to our project, because of course now we understand the impact of our food system, but what is the role of the healthcare setting? Well, the healthcare system is responsible for 7% of greenhouse gas emissions in the Netherlands. And as I've already mentioned, they're transitioning to a more healthy and sustainable setting. And part of this is to move to a plant-based diet. But of course, there's always a but when it comes to research, otherwise there would be nothing to research. And the but is that animal protein has a higher quality than plant-based protein. I'll dive into that in a second. But as you might know, protein is very important for recovery in patients. A normal healthy adult needs around 0.8 grams of protein per kilogram of body weight, whereas a patient needs a bit more. So it's crucial that the protein intake remains adequate. But if you move to a plant-based diet that has a lower quality, will this then still be adequate? So protein quality, what is that really? Well, it is the bioavailability of protein for our body to make protein. So when we consume protein, it's digested and it's broken down into amino acids, and these are then used by our body to, for example, build muscle or build bone. And protein quality depends on two aspects. The first one is digestibility, how much of the protein can actually be digested. And as you can see on the graph on the right, animal-based products have a higher digestibility factor than, for example, legumes or nuts and seeds. The other aspect that's important when it comes to protein quality is amino acid profile, which I'll explain in a second. But what is important to know for now is that our body does not have a amino acid storage, which means that whatever is broken down in the moment when you consume protein is also used in that moment to build protein. So it's important that we have an adequate and high quality protein on a meal level, which is why currently hospitals aim at consuming more than 20 grams of protein per meal to allow for optimal protein synthesis. And then when we look at the amino acid profile, of course, a protein can contain different amino acids. There are 9 that are essential because our body cannot make them, so we really need them from our diet. And we also need those in a specific requirement. What is important when it comes to amino acid profile is the limiting amino acid. This is the amino acid that is present in the lowest amount in 1 gram of protein compared to its requirement. So in this example, for example, it's methionine and cysteine. And basically what the limiting amino acid does is it determines the availability of all the other amino acids to be utilized. So if you draw a line on top of the limiting amino acid, everything that falls above cannot be used by our body for protein synthesis. So that's why it's really important to keep this, this profile high and have enough essential amino acids. And animal-based protein has a higher quality and usually has higher amounts of essential amino acids and therefore less limiting amino acids. But the good thing is that if you combine different products that have a different protein amino acid profile, you can actually utilize all those amino acids in the same moment and have a complete amino acid profile. So in this example, there's a legume and a cereal, which have different amounts of the essential amino acids that if you combine them, you have enough of all of them to meet your requirements, and therefore you have a complete amino acid profile. So what we did in our project was that we analyzed the protein quantity and the quality of the hospital menus, and we also looked at the environmental impact, and we also did some small scenario analysis for protein quality. We looked at adult patients that were following a basic healthy diet, complying with the Dutch dietary guidelines, or proteins following an energy and protein-rich diet. And we looked at the dinner menu options that were offered in the spring 2023, which usually have a protein component, starch component, and a vegetable component. And there's always either a vegetarian option available or an animal-based option. We used different databases for this. For the protein quantity and quality, we looked at the protein content and whether it met the 20-gram criteria. For the amino acid information, we used the database available at Wageningen. We checked protein quality with the PDK score, which is a score that measures protein quality. And we also looked at how much protein was digestible when you corrected for digestibility factors and how much was utilizable when you also corrected for the amino acid profile. And we identified which amino acids were limiting, and then we checked the environmental impact with the RIVM database. And here are some results. What we saw is that animal-based meals usually met the 20-gram criteria before correcting for protein quality, and most meals, 68%, also complied with the 20-gram criteria when you corrected for digestibility and amino acid profile. However, for vegetarian meals, that was not the case. We saw that it dropped significantly when correcting for protein quality, so only 20% of the vegetarian meals complied with the 20 grams criteria when you corrected for protein quality. And what was interesting to see was that this drop in protein availability that was utilizable after correcting for protein quality was that it came mostly from the digestibility and less so from the amino acid profile. So it's really important to take account this digestibility factor when you plan your meals, especially for vegetarian meals. What we also saw was that the most common amino acid that were limiting were lysine and leucine. And then we did some small scenario analysis with the Alpha tool. I think Annemieke is going to explain a little bit more about these tools, but it's an optimizing tool that basically tells you which combinations you can make within a meal to reach a high protein quality score without having to increase your protein intake very much, which is very interesting for patients because their appetite is already quite low, so you don't want to increase the portion sizes a lot. And then for the environmental impact, what we found was that vegetarian meals had on average 50% lower greenhouse gas emissions and compared to animal-based meals. And in animal-based meals, this mostly came from the protein component, and especially beef had a very large impact. So it's according to the research that has been shown at the beginning. So yeah, the takeaways are that it's important to take protein quality into account when designing meals, especially the vegetarian ones. The good news is that it mostly comes from what we saw from this digestibility correction, and these factors are available. We also have them in our report, so this is something that can be applied already. And when it comes to the amino acid profile, that's a bit more complicated to calculate, but there are tools available that are also available to use. And yeah, as expected, the vegetarian meals were more sustainable. So there is definitely a reason to move to plant-based diets. And the nice thing about the scenario analysis was that we saw that it's definitely possible if you make these smart combinations with products that can complement each other for the amino acid profile. But yeah, this was just a small sneak peek. We have a lot more information in our fact sheet and our report. Yeah, and I hope that you enjoyed this presentation and it gave interesting insights. And I'm happy to answer any questions after Annemiek's presentation. Thank you.
Yes, hi everyone. I shall start sharing my
screen. Annemieke, would you like to share your slides? Thanks. Okay.
Yes, is it visible for everyone?
Yes.
Okay, nice. Well, thank you. Thank you to be able to tell you something about our experience and knowledge on the protein transition in clinical practice. I've been working as a dietitian since 2009 at the UMCU Utrecht within our oncology team. I finished my PhD focusing on optimizing exercise and nutritional care for patients with head and neck cancer. And since 2021, when the UMCU Utrecht joined the Goede Zorg Proefje project, I acted as a project lead, and we have set some steps towards more healthier and more sustainable food at the hospital. And besides the project Celia told us about, I also joined our NFU Green Deal project, Sustainable Nutrition in Healthcare, in which we developed information for patients and tools for professionals, and also toolkits for facility departments. And I would like to tell you some more about the protein transition in clinical practice. And I think most of you are researchers because it is focused on research, and I assume you may have limited experience within hospital environments, and particularly with food services in the hospital and dietary treatment. So to help you understand the challenges within hospital setting, I will provide you with some background information about the hospital food services. And then I will tell you about dietary treatment for patients and the protein requirements, and also the opportunities and challenges for the protein transition in clinical practice, and the tools that are currently available. So at the hospital, of course, food safety is a major topic because the patients at the hospital are very vulnerable for infections. So we have strict protocols for food safety. And as we serve approximately 400 evening meals per day, we also have to have reliable suppliers for food delivery, who are capable of delivering consistent volumes, since we cannot adjust our menu on short notice. We need to have enough room for storage, for transportation. We register waste, and we have to be able to cook the meals, and we have a system of that the meals are prepared centrally and served later. So that's called decoupled cooking process. And every step we want to change at the hospital requires a lot of other steps. For example, when we wanted to switch towards more whole meal, whole wheat pasta. That was very challenging because it was not available in the required packaging size of. It was only required in half a kilo consumer packages, where we needed 5 kilo packages. This is just an example where the steps we have to take in a hospital before changing one project. And also we have to take into account the cost of the meals because we don't have unlimited budget, the palatability, of course, the taste of the meals, and the suitability. For every meal and for every single component of a meal, it is checked by hand if it meets the dietary requirements of the patients of the different diets in the hospital. Because when patients are admitted to the hospital, they are screened for malnutrition. So nutritional risk is assessed, as you can see on this picture. And part of the patients have no risk for malnutrition, and they can receive a standard diet which meets the general requirements for the general population, the Wheel of Five, as we call it in the Netherlands. And I think about 30 to 40% of our patients have a standard diet. But on the other hand, when there is a high risk for malnutrition, they have other requirements, and they will receive a protein and energy enriched diet. And about 25 to 40% of our patients are at risk for malnutrition. Besides malnutrition, there are other diets we have to take into account. For example, some patients with kidney failure need specific diets, or patients in preparation for a medical treatment, they need specific diets, and we have several texture modified diets in the hospital. So we have about 30 different diets, and patients can also have combination of different diets. So that's very large setting, and very much you have to take into account. And the average length of stay in a hospital is about 5 days in the Netherlands, where maybe we can state that at a universal medical center, we see more complex cases, and the average length of stay will be a bit longer. But after very large surgeries, patients will stay, I think right now, a week at the hospital, whereas previously they would stay 2 weeks. It's very short time to also to change behavior. And why do we focus on malnutrition? Because in the hospitals we always talk about malnutrition, and obesity is a much larger problem, we think. But in the hospitals, 25 to 40% of patients have a high risk for malnutrition, and that is related with negative health outcomes, as seen on this sheet. It increases the risk for complications and infections. Wound healing is diminished. Also, condition of the patient diminished, and the quality of life. And that is related with a longer duration of hospital admission and higher healthcare costs. So as clinical dietitians, we mostly treat patients at risk for malnutrition, and they have specific requirements. Energy is provided according to calculated needs based on resting energy expenditure formulas, with accounting for physical activity, the disease and stress. For micronutrients, we don't exactly know what if the needs of patients are different than for the general populations. So we provide them according to the Dutch Health Council recommendations. And for macronutrients, patients also need carbohydrates, fats, and protein. Protein is most important for our patients, because Celia already told us, unfortunately, this is in Dutch. For the healthy population, 0.8 grams per kilogram per day is necessary. And for those patients with complications or without complications, but with a risk for malnutrition, the requirements are between 1.2 to 1.5 grams per kilogram a day. So that's twice as much as for the normal situation. So how do we treat those patients as a dietitian? Well, if intake is between 75 and 100%, guidelines advise to provide protein and energy-rich foods, for example, by fortifying main meals or providing interim meals, so small snacks between the meals, and or medical nutrition. When intake is even lower, between 50 and 75% of need, medical nutrition is often needed. For example, the SIP feedings. As seen on this picture, we use about 35,000 of bottles per year of medical nutrition. And when intake is even lower, or after specific surgeries, when patients are not able to eat, they will require tube feeding. And then even with our dietary treatment, protein intake during hospitalization most often is not sufficient, as you can see in this table. These are data from 2009 till 2019. In that period, the screening of malnutrition was mandatory in the hospital settings. Patients were screened at admission. And on day 4, we had to report the number of patients who had adequate protein intake. And as you can see in these numbers, approximately half of patients had an adequate protein intake on day 4 of admission. And when we specifically take into account the older patient with malnutrition risk, they only consume less than 0.65 grams per kilogram per day. And only 4% of these older patients had an intake above 1.5 grams of 1.2 grams per kilogram per day. So there's still some work to do. And that makes it even more difficult, want the protein transition is important, as Celia told us. For the general population, it reduces the risk for cardiovascular disease, diabetes, and cancer, and about 25% reduction of environmental impact. And the current protein intake in the Netherlands is approximately 40% plant-based and 60% animal protein-based, and we want to switch that. And on average, 70% of the general Dutch population exceeds the current recommendation of protein intake for the general population. And in this general population, there is no risk for protein deficiency, as it has been stated by the Dutch Health Council, but they do advise to monitor micronutrient intake. Vitamin A, B2, B12, calcium, iron, iodine, especially when consuming plant-based dairy alternatives without added vitamins. And persons with low protein and energy intake, they are at risk for protein deficiency, and they also advise them to refer those persons to a dietitian. The goals of the Green Deal, sustainable healthcare, were mentioned by Celia. For hospital visitors and employees, it's recommended by next year to offer 50% plant-based and 50% animal-based, and in 2030, 60% plant-based and 40% animal-based. But for patients, it is stated to provide what is medical responsible and feasible. Because for patients, as I already mentioned, there is a malnutrition risk by a lot of patients. And when admitted to the hospital for a longer period, the risk will increase. They often have nutrition-related symptoms impairing their nutritional intake, but they have increased protein requirements. And plant-based protein have a lower protein quantity per portion, so you need to eat more of it to have an adequate protein intake level, and protein quality is often lower than for animal-based protein. Also, we have to take into account price and taste. Price is often mentioned as a concern because plant-based alternatives might be more expensive than meat. However, when using legumes, for example, it's less expensive. And we have to take into account patients' beliefs and preferences. And Celia already told us about the protein quality and the digestibility and the amino acid composition. And protein quality is often expressed as PDK score, as you can see on this sheet. It takes into account the limiting essential amino acid and the digestibility. This also in Dutch, but when we look at the different protein sources, for example, milk, whey protein, egg, casein, beef, soy, pea, oat, and wheat, you can see that for the animal-based proteins, they have a higher quality than the plant-based proteins. And we have to make the smart combinations within a meal for optimal protein quality. And Celia mentioned the alpha tool was used in her project, and the amino fit tool is another tool which is available. And I will focus on that tool that is freely available currently, and it calculates protein quantity and quality of a meal. And I would like to show you an example with the dish served at our hospital. It's from our previous spring menu, and it consisted of mashed potatoes with cabbage, tomato gravy, and oyster mushrooms. And this dish has a protein content of 11 grams, and you can see it's in red because it's not enough. The goal is set at 25 grams per meal to have optimal protein synthesis in the body. And it has currently a ratio of 6% animal-based protein and 95% plant-based protein. So you want to improve this the protein quality of this dish. Then the tool provides you with some products you can add to the recipe. For example, you can choose only vegetarian, as you can see on the left, or full plant-based products, as you can see on the right. So it provides you with multiple options you can choose. And for example, when you choose skyr as a dessert to add to this meal, then you have an optimal protein quality and quantity of at least 25 grams and a ratio of now about 60% animal-based and 40% plant-based. But when you choose a plant-based option to add the grilled tofu in this example, you also have optimal protein quantity and quality with a ratio of 3% animal-based and 98% of plant-based protein. So this tool is very helpful for dietitians and the facility departments at hospitals, but also at other hospitals to optimize the meals. So what is our role as hospitals and dietitians? I think it's very important to create more awareness about the necessity of the protein transition among the healthcare professionals and patients, but also to stimulate more plant-based options and less animal-based in patients, especially those without increased protein requirements. And in patients with increased requirements, we have to pay attention to protein quality, portion sizes, and patient preferences and needs. And we should use the available tools to improve the meals. If you want to read more about the available tools we developed in our Sustainable Nutrition in Hospitals project, you can go to the website mentioned on this sheet. There's also a link to the Amino Fit tool and a toolkit for facility departments and how to provide more sustainable nutrition. And also recently the fact sheet Protein Transition was published by Goede Zorg Proefje and is available via their website. So that's what I would like to tell to you from our hospital, and I'm happy to answer any questions. I will stop sharing my screen right now.
Yes, thank you, Celia and Annemieke, for these clear, interesting presentations. Curious to hear about the questions. I already see a hand. Anneke, would you like to ask your question?
Yes, please. Well, thank you both for the nice lectures. Annemieke was especially interested in something you mentioned, it's maybe a hard question, but you said very rightfully so. The extent to which you can switch to plant-based is really depending on the type of the patient and on the feasibility. So I was wondering, like, if you could like paint a broad horizon. So where do you expect this feasibility will be, like, say, in 2030 or something like that, for maybe differences in patient groups, like who would be able to have a full plant-based diet, or maybe partly, and for what reason?
Thank you for your question. Well, this is actually a research question we hope to answer in future project proposals, to study more in detail what is needed per patient group. But we have, yes, as I hope to illustrate with my presentation, we have very diverse patient groups within our hospital setting. And we always try as dietitian to provide personalized advice. But I hope, I cannot say when we will be able to answer this question. But I hope within the coming years there will become more information available from research project. We hope to start within the next few years.
Okay, so you're not able yet to have just a very rough estimation about that?
No, not yet, no.
Okay, I'll look forward to it then.
Thank you.
Thank you. Gabriela, would you like to ask your question?
Yes, so thank you for sharing your results. Very interesting research. So I work at the Copernicus Institute of Sustainable Development, and I think my colleague Brian Dermody was involved in the project, so I heard a little bit about it. So it's really interesting. I have a question about it's not feasibility, but more acceptability from patients, because of course we can optimize all the meals, and then maybe we find out that tofu is an important addition to a meal, as Annemieke said. But then, like, if the patients maybe they are not used to that kind of food and they will not eat, then of course the goal is not met. So today is my parental leave day, and I'm actually with my son, so maybe you'll hear him here. But then, I just wanted to know if you have like any insights on like patient acceptability, or if you plan to look at it in the future.
Yes, thank you for your question. I think this is a question we can both answer, but I'll try to answer it on my end. In our project, we didn't look at acceptability. I saw a question in the chat, which also links to this, which is that we only looked at the menus that were offered, so we didn't look at actual consumption. We did try to choose for the meals that are proposed by the hospital and are also usually chosen by the patients, because patients sometimes can also make their own meals, but these are the ones that are proposed by the hospital and are often consumed. In which amount, that's indeed a question. And then in terms of acceptability, indeed, what we saw with the scenario analysis, for example, is that some of the plant-based products that were offered as a solution were maybe not very realistic, right? There were like algae or, yes, like soy products that maybe are more acceptable than algae. But that's definitely something to take into account. And I think what would be interesting is if these hospitals actually start playing with these tools and see, okay, within the options that there are, what fits within the meals that they usually offer, right? But I think maybe Annemieke has a bit more insight into the real practice of this.
Yes, I think it's very important to make it more, to stimulate patients to make right choices. But how we should do that, that's topic of research still, because we as a hospital, we want to offer a choice to our patients, so they can still choose about 4 to 6 different components per meal, but you want to stimulate them to choose the right protein sources. But we still have to look into that more, and how to stimulate those more sustainable choices, and not only within our patients, also within our employees. And there are some studies in other hospitals right now, and I hope these results will help us in our communication strategies by nudging them and so on. Yeah.
Yeah, no, yeah, really happy to hear, and would love to know more. So maybe I will get in touch to see if there's yeah, any follow up and yeah, any more results. So I would love to hear about. Yeah, thank you very much for the presentation.
Yeah.
Thank you.
Thank you. Unfortunately, the time is already up, so I would really like to thank you all for your presence. I see there are more questions in the chat, so please, if you have any remaining questions, feel free to reach out to us. We're happy to answer it. Also, if you would like to talk about the Institute for Preventive Health or talk more about the research with Annemieke and Celia, I'll put our email address in the chat as well, so you can reach out to us. So thank you all for your day. Thanks, Annemieke and Celia, and have a great day, everyone.
Thank you. Thank you, everyone.